Okay, up next we have Dr. Sanuja Bose, who is a graduate of the University of Rochester School of Medicine and Dentistry with distinction in community health in 2020. She recently completed a concentration in epidemiology and biostatistical methods at Hopkins and is due to receive, is this right? That's what I thought. She has a Master of Public Health from Johns Hopkins Bloomberg School of Public Health. She conducts patient outcomes research in the Division of Vascular Surgery and Endovascular Therapy under the mentorship of Dr. Caitlin Hicks. And are you a vascular surgery fellow at this point, or? Okay, continues pursuing her dream of becoming a vascular surgeon. She'll be presenting her work on the validation of long-term stroke outcomes after carotid revascularization in the VQI Vision database. And I gotcha here. Go ahead.
Thank you. Sorry that bio was 2 years old, but I am still a postdoc research fellow at Hopkins. Just don't know what the future brings right now. Okay, these are our disclosures. So long-term stroke rate is an important metric to evaluate among different populations, but it can be difficult to accurately capture retrospectively. We recently conducted a different validation study using 2 prospective population-based cohorts, ERIC and REGARDS, which allowed us to evaluate the accuracy of ICD-10 codes to identify long-term strokes among patients with cerebrovascular disease. We found that ICD-10 codes could accurately detect long-term stroke with moderate sensitivity and high specificity. This is the list of ICD-10 codes that were recently validated among patients who had cerebrovascular atherosclerotic disease. So this led us to wonder, are these findings also applicable to patients who have undergone carotid revascularization? And a very useful data set to investigate this was the Vision data set, which is the VQI matched to Medicare fee-for-service claims in order to allow us to evaluate longer-term outcomes. So our research question became, how accurately can ICD-10 codes detect long-term strokes among patients who underwent carotid revascularization? So we used the institutional VQI datasets from 2 of our institutions and looked at all patients in the carotid revascularization for CEA and the stenting databases between January 1st, 2016 and December 31st, 2019. We excluded all patients who didn't have linked Medicare data, and then we looked at the procedure types and excluded any patients as well who had any sort of atypical hybrid procedure or any patients who had more than 1 procedure during that study period. So we included all patients then who had an ICD-10 claims code for stroke in the Vision database. And we used stroke codes, whether it was the indication for the procedure or if it was a postoperative stroke. We then used a random sample, 1-to-1, in order to add stroke-free patients to that cohort. And we ended up with our final study cohort, which was notably oversampled for stroke based on these methods. So we had 3 physicians who were blinded to whether or not the patients had had a stroke based on the ICD codes, who completed a comprehensive medical record review of all the patients in our final cohort. If a stroke was identified, they documented the type, and all ischemic strokes were considered the true postoperative strokes in this study, and that became our gold standard. We then evaluated the ICD-10 codes against our gold standard. We used contingency tables or 2x2 tables and calculated the sensitivity and specificity of ICD-10 codes, both in the primary position in Medicare or any position. And we also had some secondary outcomes with additional statistics to look at these. So altogether, we ended up with 199 patients between our 2 institutions, about 73 years old, 37% were female, and about 62% were symptomatic at the time of their index procedure. And then the distribution of endarterectomy, TCARs, and transfemoral carotid artery stents. In investigating the outcomes, we ended up censoring 12 patients who had had an in-hospital stroke as according to the VQI definitions. We then, with chart review, identified 20 long-term strokes that occurred either in the hospital or in the office setting, and we identified 18 long-term strokes using the ICD-10 codes. So this is one of the contingency tables that we ended up creating in order to evaluate the ICD-10 codes in the primary versus any position using our gold standard as the comparison. So we could then calculate the sensitivity and specificity to evaluate the accuracy. As you can see here, the sensitivity was quite poor if we looked at only the primary position, and specificity was unsurprisingly incredibly high, especially among asymptomatic patients. When we looked at the codes in any position, it was evident that the overall accuracy was much higher, with the sensitivity among asymptomatic patients reaching 100%. Among the symptomatic patients preoperatively, sensitivity was lower, which is also what we expected, with a stroke code from a past admission being more likely to carry over into the future. And this was true even after we had censored those patients who had an in-hospital stroke after their procedure. So we learned quite a few things along the way in determining what created the greatest accuracy in this data set. And one of those is moving forward recommending that people do stratify by symptom status when reporting outcomes, because there is a great significant difference between the two. So in the end, we did find through this validation effort that our recently validated ICD-10 code list is able to accurately identify long-term strokes among patients who also underwent cerebrovascular, in addition to cerebrovascular disease, also patients who underwent recent carotid artery revascularization for carotid artery stenosis. In the future, now that these codes have been validated, it will allow investigators to more accurately capture long-term strokes for carotid revascularization using different administrative claims databases. And thank you to our team and everyone.
All right, this paper is open for discussion.
My understanding is that with using vision, one of the issues in the past has been laterality, identifying that the stroke was ipsilateral to the carotid endarterectomy. And how did that work in the analysis here?
That is an interesting question. We also do a lot with like PVIs, and that is often like a greater concern with that. We aren't able to determine laterality, and so that is a limitation. Yes.
Great work. So my biggest question for you is that this looks like to me, the way I'm looking at this, that this is pretty accurate. That what Vision has is pretty accurate, because we had a project that was accepted to American Surgical, and we had to take the stroke out because it was thought that the stroke might not be accurate with Vision, and we last minute kind of changed it only into mortality, and the paper was published in Annals based on waiting on this project. So my question to you and Phil here, so how does that apply? Is there any more work is going to be done, or do we now say that we can use carefully Vision data?
So our hope, like we've worked with the committee, and our hope through this process, we have both not only gone through this to validate the long-term outcomes, but we've also created an algorithm in order to help guide people through the VQI definitions to help determine like which steps to follow in order to most accurately create these outcomes from the beginning to end. And so we hope by being able to get this approved by the steering committee with this data that we'll have a more standardized method for people to follow when they use the VQI and Vision. But yes, based off this, it was exciting to find that they are accurate, and we hope that moving forward that there will be like a more standardized process to use these.
Yeah. I mean, if I recall with the analysis we did, some of the stroke rate was too high to believe that this is really acceptable. At the 1 and 2 and 3 years that we looked, I believe, some of the stroke rates were almost 20% in some of the groups, whether it's the CEA or the TCAR. And a lot of people will look and say, why are we even operating on these patients if they're going to have a 20% stroke rate? So I don't know, maybe Phil can also guide us through this.
Yeah, I'm not sure about that population, but I know one thing that we have to emphasize a lot when we do publish this is that based on the way that these methods were done and the population was created, it will potentially alarm people to see the stroke rate that we report, but it's because we used a population that was oversampled for stroke in order to complete this validation effort.
Yeah,
Dr. Goodney.
I think Sanuja did a nice job of summarizing it, but Mahmood, so the short answer is this new algorithm, yes, it does work very, very well. It's exceedingly sensitive and specific, and it improves on some of the older definitions that we had, which seem to sort of capture too many events. The way that we can be sure that, and kudos to Dr. Hicks and her team, that this identifies events where they happen and doesn't identify events where it doesn't happen, is to have a cohort of individuals where you can look at them through several lenses. They appear in these randomized trials, they appear in our medical records, so we could have a gold standard and then see which algorithm of codes also comes up with the right answers. And kudos to Sanuja and her team and showing quite elegantly how nicely this works. And just a comment to Jens, we looked at your question about sidedness of the stroke event. We didn't explore that here, just because it sort of, we wanted to find the foundational event of the stroke, but that's some of the work that we'll look at, in the future.
Thanks, Dr.
Yeah,
Goodney.
so nice work.